Welcome to this webinar by Australia's National Research Organisation for Women's Safety. I would like to begin by acknowledging the traditional owners on the land of which we're meeting, the Wurundjeri people, and also acknowledge the traditional owners of the lands in which you might be watching the webinar from. I pay my respects to elders past, present and emerging. Today's webinar is titled, How Can We Enhance Routine Screening? Strengthening Identification and Response to Domestic and Family Violence in the Antenatal Care Setting. I'm Laura Tutsia. I'm a researcher in sexual and domestic violence at the University of Melbourne, and I'm going to be facilitating today's webinar. I'd like to introduce our panel members. And if you want to read more about all our panel members today, you can actually read their bios on the registration page online. So today we've got Kelsey Hegarty down the end. We've got Trish Ryan sitting in the middle there, Anne Ingram and Adele Sheridan-Magro. Just to go over the format of the webinar today, what we're going to do is we're going to have each of our presenters speak, and we're then going to have some panel discussion amongst the members here. And the audience will have the opportunity to submit questions. Now there's a blue hand at the top of the screen, and if you click that, you can type in your question. And those questions I'll then relay to the panel. So I think that's all the housekeeping things. So I would like to introduce Kelsey Hegarty from the University of Melbourne. And Kelsey, would you mind telling us about the forthcoming report, Sustainability of Identification and Response to Domestic Violence in Antenatal Care, which is otherwise known as the SUSTAIN study?
I'd love to. So just to expand on my what I do, I'm the Chair of Family Violence Prevention at the University of Melbourne and the Royal Women's Hospital. But I also have the privilege of working with a team of researchers, survivors and practitioners at the Safer Families Centre, and particularly the people who worked on the SUSTAIN study with me acknowledge their work, Joe Spangaro and Jeanette Walsh from New South Wales, Jane Cosiel-McCain from New Zealand and Jenny Chapman from the Women's Hospital. We're very keen to equip health practitioners and settings with tools to address domestic and family violence. So the SUSTAIN study had this focus in antenatal screening, and particularly not just screening, but first-line response, because they've actually got to do something after they identify. And pregnancy, as many of you will know, is an opportune time for early engagement with women. As domestic and family violence might continue from before, it might start or sometimes it stops. But women are usually able to go to the doctor and to the nurse and the midwife in health services, and particularly go for their pregnancy care. And we wanted to understand in this project what would support effective screening, risk assessment and response in the antenatal care setting. And it is a complex system. I'm sure we're going to hear from the others around that. And we wanted to examine the barriers and how to overcome them and facilitate sustained domestic and family violence screening. Now how did we do it? We used a case study approach across 6 hospitals, 3 in New South Wales, in rural and urban areas, and 3 in Victoria, because we had this opportunity that New South Wales, and we're going to hear later about that, has been doing it for a decade. So that's a really good place to learn some lessons from. Whereas in Victoria, we've just been introducing it in the last couple of years with mandatory screening in antenatal care. So when we went to do this, we actually built on another ANROWS funded project called the WITH study that Laura and I had done, where we particularly were focusing on women-centred care and practitioner-centred service for women who had mental health issues and sexual violence. And we used, you know, when you're trying to enact a new practice, it's very difficult to just say, okay, let's do it. Let's just screen. That's just not going to work. And the same with, let's get mental health services and sexual assault services to work together. So in the WITH study, we found that relationship building between services and integrated coordinated care was important. And we also found that a reflective system and looking at the infrastructure in environments and workplaces was important. And we used a theory that's just called the normalisation process theory. And we use this theory in Sustain again. It's basically trying to think, how do you embed a new practice? And we did the case studies by listening carefully to the voices of women and practitioners. We asked them what would enable them to, be comfortable to be asked, the women, but for the practitioners, what would help them. And they told us through surveys with over 1,000 women and a small number of interviews as well, and some focus groups with around 91 antenatal clinical staff, what's important to them. And then a gang of us got together and synthesised, we were all clinical researchers, and synthesised that research and came up with a transformation model. So the key findings, what did we find? We found that women want to be screened. They do. They want to be asked and responded to as long as it's non-judgmental, holistic and empathic, and at a time that's right for them. So they may say no because they don't feel like they can trust that particular practitioner. Practitioners actually want to screen, I think, and respond if they're equipped and supported by the team and the organisation. And the clinic needs to be clear on the roles and processes, but they need to be supported by the leadership. So it's at the patient, the woman's level, the staff level, and the clinic and the system level. And all of them need to have ongoing reflection and feedback to inform the improvements. So those are sort of the key messages. So this new model called REAL, we're going to talk about it a bit later in this webinar, but it was a focus on how the work gets done, and that really started to build on this relational idea. So is the practitioner relating to the patient, but also how are staff relating to each other? And if those are not in place, that basic relational is not in place, that's a problem. Engage is actually, it's really important how you do the engagement with each other and with women. But then once you're doing actions, practical actions, how do we able to support at the clinic level and the system level? And then how do we learn? So those are the mnemonic for REAL. So how did it work? We got great buy-in from the hospitals involved, and the preliminary findings were fed back to some of them, and that informed the rollout of the screening in some ways. And it was my first experience of a lovely intersection of policy change, practice change and evidence building all in the same time frame. Usually they're out of sync. So that's just the introduction to this area, and I'm looking forward to hearing what the others say.
Thanks, Kelsey. And as Kelsey mentioned, we're going to be talking a lot more about the REAL transformation model later in this webinar. And also to read more about the Sustain study, which is a fantastic project. The report is going to be released soon as well, so you'll be able to read more about that. So moving a little bit away from the research to practice, different jurisdictions have implemented domestic violence identification and response practices in antenatal care services in various ways. So our next three presenters are going to talk a little bit about their experiences of doing screening in practice. So first, we're going to have Trish Ryan, and just to give some background, she's the manager of the pregnancy clinics and childbirth education at the Royal Women's Hospital in Melbourne. So Trish, maybe you could tell us a bit about how domestic violence screening has been implemented at the Women's, and I guess a bit about the experiences of the midwives in doing that work.
Sure, happy to. So building on the what Kelsey has said, that we had lots of them workshops at the hospital, because as Kelsey said, she also works at the Women's and is head of our family violence thing. So we were not doing any screening whatsoever at the Women's, so it was a completely new concept to us. So we had terrific buy-in from the executive team and all the midwives, and we had lots of workshops. So we were all very, very energised, I think. One of our key challenges was that, just for context, and like a lot of big tertiary hospitals, we care for 7,500 women's annually. So what we decided to do was just to pilot it on one day of the pregnancy clinics first, just to try it before we buy it, instead of trying to do a big bang approach and then mucking it up. So what we also did is we've developed the tool which is in part of the pack, the relationship and safety tool, which is has the specific questions about family violence. We've also formalised how we ask women about their drug and alcohol use and their mental health when they first come to the hospital. So I put these 3 forms together, and that was going to be our new package of how we tackled introducing how to do this screening for the pregnancy care. So what we did was at the booking appointment, women would come to the desk, they would check in, and then the clerk would give them a folder, and it had 3 forms in it. One was their pregnancy history form, which they filled in. Then one was the emotional wellbeing form. And then here, which was the key to our success really, was that we decided the only way really that we could screen women appropriately was to do it on their own. So what we introduced was a 10-minute women-only consultation time. And we, at the Women's, we decided that we would do that first, and then we would ask the partners in. Because we know from talking to colleagues around the country that sometimes it was is harder getting partners to leave
once they're in.
Yeah.
Once they're in.
Excellent.
Whereas if we set up the expectation at the beginning, that we just had this at the Women's. This is how it is around here. So we've had signs in the waiting rooms, we had signs in the check-in folders that this is what happens. That the first 10 minutes of the appointment is with the woman only. One of the key things that the midwives, midwives thought that we were being a bit bolshy about that because we pride ourselves as midwives as being very inclusive of families, but here we're saying, no, we just want to speak to the women. The other thing that was also daunting for a lot of us was having the confidence to be able to ask the questions. We're a teaching hospital, so we have midwives who have just their first day out of university to midwives who have been around for a long time, and it didn't matter where they were in the spectrum of their careers. Midwives did find it challenging asking the questions. So we had lots of education sessions, and those of you that work in hospitals think, well, how did you get lots of education sessions? Well, we had to do everything in double staff time because you don't get any extra time. And we did role play, which midwives hate, but I know social workers love. So that was
We don't really.
yeah. And sorry, just set the training, and then midwives, they got used to doing it. I think one of the other challenges, which will be not new to any hospital in Australia, is that the booking in visit is only whatever it is that your hospital says. You don't get extra time to do this work. So, which is part of the reason why we decided to give the women these pre-questionnaires that they could fill in the waiting room before they come in, so then we could quarantine 10 minutes of the time to do the family violence screening.
Yeah.
I asked the midwives this morning in antenatal clinic, what did they think about it, because I told them that I was coming here to speak and to learn a bit more, and they said to me, which was very pleasing, it's just business as usual now. So they just find it's just normal, that's just what we do. And they find that they've had no trouble with partners saying, no, I'm not letting you speak to my partner on their own. And the other thing which surprised me a bit was that the midwives, some of the midwives this morning, they were actually surprised at how many women say that they have experienced family violence.
Yes.
So that was a shock to them. And then just one of the things that they did talk about, which I'll have to take back to my own organisation, was just ensuring that we've got the pathways right, that if someone identifies, then we've got somewhere for her to go.
Yeah.
But mostly I would say business as usual, and yeah, it's been good.
Yeah.
And how about from the perspective of the women themselves? Like, have you had feedback from them about how it's been to be asked about this issue
Yes.
in the process that you've now formed there?
Yeah, just a couple of women have spring to mind. Before we'd formalised this, I actually got a complaint from a woman because she said that in her booking appointment she'd heard that we should be asking out in the world, but we weren't at the Women's. And then she asked her midwife, "Oh, aren't you going to ask me about family violence?" And the midwife said to her, "Oh, but you don't look the type." So it was interesting. Like there's that was that. And then we've had some other women who say, I'm really pleased that you're asking about this. One woman was a lawyer who does a lot of family court work, and she said it's so important that you're screening, so thank you very much. So mostly the women are fine. And I think the other thing for learning, if there's midwives watching, is that we always assume that it's the male partner, might have been the perpetrator, but in fact what we've learnt in this process, that it might be a mother-in-law or another member of the family. So even when you're inviting the women in and they say, oh, it's all right, it's just my mum, you've still got to say no, we just still want to...
Excellent point.
Yeah, meet you on your own.
Yeah, excellent.
Thank you, Trish. I'd like to invite Anne Ingram to comment as well. Anne is a senior social worker from Western Health, and she's worked on the Strengthening Hospital Responses to Family Violence project as well over there. So Anne, maybe if you could tell us about how Western Health's implemented routine domestic violence screening into antenatal clinics, and whether there's been any differences there from what we've heard about so far.
Yeah, sure. So Western Health, I guess, ran a bit of a different pilot study. So we called it the Wellbeing Clinic, and it was a very small scale scoping project, really to look at feasibility and how we might move forward. So it was a 12-week trial with one maternity team in the antenatal clinics on 1 day per week. It was a social work-led screening clinic, and I guess what we were looking at was a way of measuring how many women would take up the opportunity to screen. We screened for perinatal mental health, for legal issues, and then for family violence. So we did the 3 screening tools, and we wanted to see how many women engaged, how many women opted out, and then we wanted to look at EFT staffing, how the flow, patient flow travelled when we received disclosures, what happened then, what service support systems were in place. We wanted to see how we worked with, and it was a collaboration with the mental health service along with the midwives and social work. So we wanted to see what a model of collaboration between those 3 disciplines and alongside our health justice partnership. So we have a family violence legal clinic, and they were involved as well. Women were offered this appointment straight after their maternity assessment clinic booking. So they would see the midwife and then be offered this time with a social worker to talk about things other than their medical questions. So our model relied heavily on framing. So we would have women come in directly after their first appointment, and we would talk about the importance of other things that impact pregnancy. So we would introduce that, they'd have lots of opportunities to talk to midwives, doctors, about medical questions, about the baby, about the pregnancy, but this was their chance to really talk through anything else that might be impacting them. So we would introduce a little bit of psychoeducation in that around, we know family violence impacts people, we know legal issues impact people, and so does your mental health. So this is a chance for us to together talk about the things that may be impacting you and make some decisions about supports you may need following this appointment. So over the 12 weeks, we saw 91 women, so very small study in comparison, but 4 women declined. So they declined before they came around to what we call the Wellbeing Clinic. 1 woman declined from clinic, so she came in and didn't want to do it, and that's okay. Anecdotally, she did tell us that this is great, but it just doesn't apply to me, so no thanks, I'm busy, and that's okay. 34% of women attended with a partner, and we made the decision in this small project to not try and navigate partners leaving the room, so those women would just not ask the family violence portion of the questions. But we did do the perinatal mental health and then the legal health check. And interestingly, we did have a number, and I haven't got the percentage with me, but we did have a number of women who, when we got to the legal health check, would disclose histories of family violence either as children or in previous relationships quite readily in front of partners. So, and women who didn't have their partners there did the same. So we often didn't even get to the family violence questions before we received a disclosure. 37 women of the 91, sorry, I'm just checking my notes, 40% of the women booked didn't receive the family violence screen. But of the women who did receive the family violence screen, we received an 18% disclosure rate, so quite higher than we expected. One of the other interesting learnings for us, I think, was around that sort of wraparound multidisciplinary model. So because we were asking perinatal mental health questions and legal questions, we found, and we had some data received from the Perinatal Mental Health Service, that of the women we referred into perinatal mental health services, they had a higher uptake. So they had a 28% DNA rate of women who were referred through from Wellbeing Clinic, as compared to a 47% DNA rate for other women who came through the midwifery service. We chose a social work-led model, and I'm sort of going around a bit, but we chose a social work-led model really around scopes of role, and we wanted to support the midwives. So we know they're really time pressured, have a lot to cover in their appointments. So we wanted to support them and work together within our scopes to sort of, support each other's work. So social workers, violence and trauma-informed care is our core business. We felt that we were well placed to screen and provide wraparound support and link women in after their disclosure, either with our social work service in the hospital or where risk was higher, directly into specialist services. But we also felt that the midwives were supported in really concentrating on the things they felt were a priority in that booking assessment, knowing that we would be talking about those other factors for women afterwards. So I think we received lots of positive feedback from women. We had women talking about how great it was to be asked. I had one woman say, look, it doesn't apply to me, but I think it's fantastic that you're asking. We really had a great uptake, and I don't think we received any negative feedback per se. We had those 5 women overall decline screening, but I think we learnt a lot about social work role in screening, social work role in holistic care, and about sort of warm referrals and the benefits of having that sort of multi-screen approach and looking at the whole social picture of a patient and how that linked in with those other services, and the follow through was we found really positive, but it's early days and a small study, so we'll see how we go. Yeah.
Sounds great. Excellent.
Yeah.
Were there any challenges that you found around working with that model? Because it is a different model.
It is, yeah.
What would you say are the main challenges with doing it that way?
Yeah, so I guess at the beginning of the trial, we worked on a booking system where women would be booked for their assessment clinic, and then they would have an appointment with the wellbeing clinic straight after. That didn't work. So for about half of the trial, we had women turn up. Some told us they didn't know what the appointment was for, or they hadn't received the letter. That was a bit of a problem. So about halfway through, we changed to a walk-in model where we had social workers there in clinic ready to have women taken straight through from booking. So that was a learning that I think for women, they didn't always understand what it was about until they met with us. But once we met with them through the walk-in model and we framed the screening around, it's holistic, it's your chance to talk about things, and let's together plan what the next steps are. There may be things affecting you, and if we together can talk through, and we'll use these tools to help us think about all the different things that may be a factor for you at the moment, we can together make a plan that supports your pregnancy. And I think that on reflection, I think is probably one of the successes of the model was the framing and the supportive conversation. Yeah.
A bit resource intensive.
Yes.
That's what I was going to say. Like, how did you manage that with the walk-in model, having the social workers just available there all the time?
We had to have 2 social workers available, so EFT intensive. So I think that will be the biggest challenge going forward is we're working with the midwives who are really, they were really pleased with the flow, the patient flow and support, and we always provided a handover afterwards, so they were happy with the model. It's just about how we make it work and how we get enough feet on the ground.
They're so women-centred, but that one is as well.
Yeah.
The women's where they actually fill out a form in language that's very nice and empathic for women. Exactly the same, a relationship and safety tool. So this idea that you can have different models that are women-centred.
So I'm really interested to see with the sustain model what we can sort of use to tweak our model, hopefully, to make it more sustainable. Yeah.
Excellent.
Yeah.
Thanks.
Thanks, Anne. I'm going to introduce Adele now. She's the Manager of Domestic and Family Violence Services at St Vincent's Hospital in Sydney. Now, Adele, New South Wales hospitals have completed mandatory routine domestic violence screening in antenatal clinics for over 10 years. They've been doing it for a long time. 15 years. Yeah. So you've got a lot of experience to draw on there. But from a social work perspective, what do you find is the response once a woman has disclosed?
Thank you, Laura. First of all, I'd like to really acknowledge that what I'm going to provide is my experience, but it has been in a metropolitan tertiary maternity services. in hospitals within the metropolitan area of Sydney. I'm pointing that out because I haven't worked rural. And so I can't speak for all of New South Wales. So I think that's important to acknowledge that. So, and I think from a social work perspective, what we need to critically always reflect on is that the screening process, the domestic violence screening process, is not a neutral experience for either the woman or the midwife, or because midwives only in New South Wales. It's not neutral, because if we look and we know what research and the statistics are telling us, that 1 in 3 women have experienced or know a close friend or female relative that have experienced violence and abuse sometime in their life. So that's a critical acknowledgement that I think is often not put out there. And from that social work perspective, that is what needs to be acknowledged, both through supporting our colleagues in midwifery who actually do the screening process, and us entering the room, and the woman herself. So I just wanted to acknowledge that. And I think the third thing that we've really come to realise is that, again, as research has absolutely shown us, is that most women are open and are certainly getting more and more open to being screened and having this horrific blight on our society out there, and saying we're acknowledging this. But at the end of the day, women present to a maternity service to book in to have a baby. They haven't presented to a domestic violence service. So it's that critical acknowledgement that is, we need to acknowledge that. So once the woman has disclosed to a midwife, I worked in a maternity service that there was very well resourced with social workers. It was a team I managed, and we had literally 6 social workers in the antenatal, covering the antenatal clinic and other parts, but and it was an immediate response through a paging system. Now, that had been set up for a number of years, where a midwife, any disclosure, a midwife knew that the social worker would be there. And it was that consistency that proved very positive, and it really did bring up best practice from that systems perspective, that midwives knew there would always be a social worker there. Yeah. So, no, and that's why I pointed out in the beginning that I can speak of a well-resourced tertiary hospital, right? Okay, so from that former the trauma-informed perspective that is so well talked about and paraphrased these days, we really have to, as social workers, wear that lens when it comes to being woman-centred. And what we have found as social workers, once there has been a disclosure of current domestic violence, is how that social worker, the service of social work, is introduced to the woman. And there was a lot of ongoing education around introducing us, with your examples, which have been excellent, as part of a whole of service response and a care team. So we were constantly encouraging midwifery to introduce us as we are part of your care team. It's your care team. So that's very important. And just, how am I going for time? Okay, and just very important too. So what I think critically needs to be acknowledged is that what has been disclosed is a woman is told us that she is living with and in complex trauma. And it's from that lens a social worker must enter that room, right? We know the term domestic violence, and you know, to a lot of different women from different backgrounds, ethnicities, the term domestic violence doesn't even register. But what registers is you're living in a violent, abusive, and trauma laden lifestyle, and that's you know you're being impacted by. So the skills the social worker needs to bring in, and what needs to happen is really the core responsibility for a social worker in that setting is to do risk and safety planning. It's part of our core assessment, and we are doing it for not only the woman, but for the unborn and the woman's children that may be in her care. So it's not a case of just one-on-one with a woman. We have to hold many balls. And that can be profoundly difficult. And while keeping that trauma-informed practice front and centre. Yeah. So because social work, what I've seen anecdotally, what research has told us, is not that again, introducing social work to some women is not a neutral experience. If it's an Indigenous woman, that's not neutral. Because we walk in with the weight of our profession behind us. We walk in with perceptions and values that come with our discipline. So it's vital, and it's the responsibility of social work to do everything it can as a profession to break down the silos in health and work far more closely with midwifery and in the multidis team as being part of the care. And holistic care for a woman. Because sitting on its own as social work can be counterproductive for trauma-informed practice. So social work still, although we do a great job, we've got a lot to do and a lot of work to do to work with these wonderful midwives, basically. And of course, let us not forget how vital working with the medical profession is.
You didn't just say that because I'm a
No, I didn't. Actually, I didn't even know. No, it's so yes, it is working, and I've seen it get better in New South Wales. Just to sum it up, if we've got 1 second, and the practice, and there is more people, professional people wanting to. Be what I would say do in trauma-informed screening and then the interventions, but we cannot just rest on. We've got to continually say, look, critically, how can we do this better and safer for women and their children and their unborn.
And with them, with the women.
With them, oh, absolutely. Yeah.
Thanks, Adele.
Thank you.
Well, that wraps up the speaker session, and thank you all very much for all those contributions. They were really great. So we're going to move to a panel discussion now, and we're going to focus a bit more on the real transformation model and the SUSTAIN study specifically. So maybe, Kelsey, if you could explain the real transformation model in a bit more detail than what you did before, and we'll then open up to the panel and maybe have a chat about how that model could be implemented in practice.
So you've actually mentioned many of the things that are in the real model, and I think that I'll just go through each of relate, engage, act and learn. And the model, when it comes out, is really going to try and have some reflective questions. It's got a video of each of us explaining the different areas. It's got scripts and some tools for people, because when we listened carefully across these 6 sites, we do see differences between well-resourced and less resourced and rural and urban, and everybody out there has can step up and have a role. It isn't just social workers' role or midwives' roles or doctors' roles, or, you know, it's everybody within the hospitals and the clinics. So to step up means that you need to be thinking about where you have resources. And the relate area is particularly around what we've all been talking about, the trauma-informed. See, you know, the women wanted to be seen all of me. They wanted people to understand their context. In terms of the practitioners, they did feel that if they had some continuity of care with a woman, if they had the collaborative team wrapping around them, and that looked like different things in different areas. Sometimes the mental health worker was actually someone who was very skilled in family violence. You know, it really varied who was that collaborative team. Sometimes it was a clinical champion of a doctor in the clinic. So, and I think that sort of mentoring by others, but also of each other, was really important. So that's the relating. The engaging is really around, you know, there are times where women might say no, as I said before. So getting the timing and the privacy, and I don't think we've got the privacy right yet. They are interested in their partners and families being involved if it's safe to do so, and that was something that was interesting to us because, of course, there's this tension we've just talked about that, you know, we're being family and then we're not, but you have to ask alone. And the cultural fit, you know, so asking behavioural questions rather than labelling questions like, are you a domestic violence victim? But the scripts and tools for practitioners, the clear pathways, and acknowledging their own experience of family violence. We've been doing some work, Elizabeth McClendon has, and there's a very high prevalence of family violence. But contrary to what many people think, we actually found that the people who experience it go to training and go the extra mile. They actually ask more and they give information more, and they're not avoiding this area. I mean, obviously, if it was very acute and very traumatic for them, they need to be supported, but that's a good thing to think about. Yeah. So then that's the relate and engage, and that's how does the work get done. But why did the work get done is really around having all eyes on it and clear role, and the leadership, as I said before, but having infrastructure. You've got to have interpreters, you've got to have things translated into different languages, and we're looking at the women's to translate the relationship and safety tool into 10 or so languages. We also have to have this feedback loops and ongoing reflection. And again, a project we're doing called the SAFE project is auditing and doing some clinical audits as well, but of the strengthening hospital response to family violence. Because if we can't do those feedback and reflection loops, then we don't know how to go back and improve the relate, engage and act part. So, you know, really there'll be some reflective questions like, you know, do I feel people have my back if I'm responding to a disclosure? You know,
absolutely.
Do I have the words to be able to ask and respond? You know, does everybody in the team have a shared understanding of the nature and dynamics of domestic violence? You know, a series of questions, and for the learn, do we reflect as a team or a clinic? So there's lots more, and there's also scripts and tools, but that's really what we've tried to make it as practical as possible. We had a nurse, a doctor, a social worker, 2 social workers in the team, so we've tried to make it very practical for you.
Yeah, excellent.
Thanks, Kelsey. And I'm going to open up to the whole panel now, but before I do, I just want to remind everyone that's watching that you can ask questions at any time. You don't have to wait till the end. So if you have a question, click the little blue hand and type in your question. Don't feel like you have to wait until we're finished with the panel before you do that. So to open this up to the whole panel now, you've heard Kelsey talk about the real model. What elements of the model do you see as being important to implement in practice, and what's your takeaway from hearing about that? Anyone can start.
I don't mind. I very much like this model, very much, because I might use different language, but to me it's a co-led model of care. Once domestic violence, and I'm talking about, has been disclosed, and we know that the woman throughout a pregnancy, and she has been living and maybe currently still is living with violence and abuse, we developed, to give you an example of this in New South Wales at the hospital I was at. We developed a model of care, and it was what we call the significant domestic violence model of care, where women who were very high risk was allocated, to use that language, a midwife, and she was the significant domestic violence midwife, and allocated a senior social worker, and that was her title, and a early childhood nurse that was brought in, and that was a co-led model of care for that very high risk group. And I think something like that, it really should be really looked at, because I think that wraparound service, and it was at that extreme end, what we call the most serious threat. But I think it really, if more models can be led like that, and it does bring that multi-disc, so it's not just, as I said before, keeping the silos of the different. Yeah, so I'll let others speak, but it was just it really was and is still a very positive move that happened in a large tertiary hospital. I'll let others.
Yeah, I think with the engage and the reflection piece, very, very important for practitioners. But I guess with my other lens on it as being the manager is, I don't know how we could actually do that in clinics when you've got 300 women coming through, and then you go off for an hour or two, which you should do, but then there's still got women coming behind that needs to be seen. So it's really trying to work out how it can,
how that team and the roles. And I think the reflection piece is the connection with, we've had a lot of students, haven't we, coming in and interviewing midwives about it, and so the reflection can't be done always by the group themselves. It might be engaging with others who can have time to do some of that crunching of either numbers or like a clinical audit, or actually interviewing people to get their feelings.
Absolutely.
Yeah, for me to be the reflection, I think the regular checking in, because I think every system changes, and I know when we did our project, without checking in with the midwives, the mental health team, the lawyer who were receiving our referrals and handovers, we tweaked as we went the whole way through, and I think without that reflection and checking in, and I think it's also a self-care thing, when you're all doing this shared work, and if reflection is built into the model, we're supporting each other.
It can be at that level, but it actually needs to be at the system level as well. So we have quality improvement for hand washing, very important at the moment. So quality improvement, you've got some numbers there. We've got some numbers from Sustain. But what does that actually mean? We didn't even know how many people came with partners until we did this work.
Yes,
So something as simple as that can profoundly change how you do something. So the numbers and the stories and how we build that into the quality improvement processes in the hospital and make it core business when it's not just the extra little project.
That's right.
Tricia, do you have something else?
No, I think it's just the important piece was, particularly in teaching hospitals, is having the scripts ready. So people then don't have to think per se of, I don't know what to say. Oh, I remember in the training.
They clearly said that.
It was very clear.
They clearly said to us that they wanted the words, even like you did before, we know that things that go on in your relationship can affect your health. Like simple words like that. Whereas I think at first the midwives thought that they were going, domestic violence, family violence, they were talking about that.
And sorry. So I was just adding to that. I do believe you're absolutely right that it's got to be that systems approach as well. That's got to be embedded. But I also believe it's got to be embedded in the educational processes before a midwife. Which it is. So, for example, and I think I can mention that UTS, School of Midwifery and Nursing in Sydney, invite as a guest lecturer, just happens to be me, but it's twice a year to discuss this, and I spend a couple of hours. So with undergraduate and postgraduate midwifery. So again, it's starting before they've even hit the floor, so to speak. Breaking that down. Look, we will work together, and we, So if that even at that level as well.
It's horrible that it's 2 or 3 hours. Like we've been looking
Oh,
at
absolutely.
this,
But it was that thinking outside the square by that particular school to say, hey, it would be great for midwives to actually meet a women and child's health social worker. And, things like that. I mean, it's just an example, but if it could start, and same with medical, in medical training. And
well, it is. It's about that level in medical training.
Is it? It's not enough.
No, it's not enough.
And I think the other benefit of, so thinking about our model, the collaboration between midwifery, legal, perinatal mental health, social work, conversations happened at there. So we would take away
relation,
together, but also outwards. So perinatal mental health team, they would go away and talk to their teams about family violence and what was happening and who they were seeing. And legal would go back to the community legal clinic and talk about what they were seeing. And sort of it's been, I think, a growth space for everybody. As a collaborative project, but also back into their areas. So I think it's sort of growth by stealth in a way. Like the more we talk about it, the more it's normalised.
And I think a challenge is the shared care GP model. And we're certainly reaching out in the Safer Families to general practice more, in a different way. But that divide between hospital.
I just have a question, Anne. And I guess I wondered about with your model and the psychosocial assessment that happened with the social worker after they'd done the kind of pregnancy medical related stuff with the midwife. I just wonder how you kind of balance that with not, I guess, furthering this stereotype that only social workers can do this work. Because I think that's something that you do encounter at times where different other health practitioners, particularly ones that do sort of the more clinical stuff, will say, oh, well, that's a social work thing. We just refer to social work.
So not limiting. I think that was around the handovers, the communication. We did a lot of education leading up to the start of the clinic with the midwifery team, but also I think just the conversations that went on a daily basis. So we would touch base with the midwives and we would have midwives that were really engaged with the process. They had done all of our training. They were really keen. They'd come to us with, we've had a disclosure. And then we might do the next step. So we might do a risk assessment and begin some safety planning. And so I think it wasn't about saying you don't ask that, bring them to us. It was about we're available. When you've finished, if you haven't got there and your time has run out, bring them around to us. And I think we did work together, and the education happened every day. Every day that we're in clinic, there was education as we went.
Because there are some people who won't go to social work, no matter how you pitch it. So certainly at the Women's, we've done a brief risk assessment so that, because the practitioners get very worried that this person might end up on the front page tomorrow. You know? And so having some assessment of high risk and referral pathways, where you're really doing that warm referral extra because,
And I think the midwives did learn a lot of, the midwives who perhaps at the beginning of the trial weren't as comfortable or were happy to have somewhere to refer, I think probably by the end were starting to ask some of the questions themselves because
having a go.
It was on the top. It was the topic. It was what we were talking about for 3 months. We were up there and we were, on about it all the time. So I think everybody upskilled through the process.
So there was still that sense that it's everybody's responsibility to kind of address this issue.
So one of our recommendations at the end that we're putting forward in our final report is that it needs to be a process that is supported by social work, but it may be legal, mental health, midwifery, screening that happens, but we want social work embedded for that wraparound continuity of care and risk assessment.
So another question I wanted to ask, and Kelsey talked a little bit about this before, and that was around practitioners that have lived experience themselves of violence. And we know from Liz's work that lots of them do, but that actually it makes them, you know, often better clinicians and they do more safety and blah, blah, blah. But I suppose in terms of practical strategies and things that an organisation and like team managers and stuff can do to actually support those workers if they need it, what would you suggest in terms of those kind of practical tips for people to support staff?
From me.
Yeah, anyone that has ideas about that.
Yeah. I guess we've got systems. You know, we've got systems around systems. Yeah, people and culture systems. We've got, you know, at the moment in Victoria with the SHRIV program, we have lots of workplace policy and procedure around where we can tap stuff into. But I think it's the same as with patients. We want it to be a safe culture. We want people to feel that it's okay to talk about it. So I think for us, it is very much a systemic response. You know, if someone in our staff group came to us and made a disclosure, we would do exactly the same with the confidentiality, the options, the resources and the planning together that we would do for
How do you even make it feel like people can come to you with a disclosure? Because often they may not want to because they're worried about the perception of what it's going to look like for them. Are people going to assume I'll be triggered, etc.? So how do you even create a space where people feel comfortable to come and tell their manager?
Yeah.
So all the managers are trained, aren't they? I know that's not a total answer, but I think that, and certainly on the SAFE audit that we're doing, we think that 100% of managers should be offered and trained because, but also I think the role of the clinical champions embedded in, you know, we need to build on that in some ways so that there is this culture. I don't know, what do you think?
Yeah, I think so. Because we, you know, as one of the managers at the Women's, I've had the all-day training about it, but mostly too, it's about them being a manager that you know your people as well, and it's back to that relationship piece again.
It is.
Because if you have relationships with people in your teams, well, then they will feel safe about coming to you and disclosing. Because I've, I don't know, sadly or goodly, I don't know, have had someone who has disclosed to me and then helped to navigate through the you know, what you have on offer. And these days, at least, like it's out there in the world, like there's HR policies now, which there never was, you know. People couldn't get special leave, but now they can, you know, and we can do something with their rosters. So it's,
It is about the relate and engage piece, I think, in the model, you know, in the organisation.
In Sydney, in one of the largest LHDs, we call them, they've actually taken that and have recognised around our own staff may be experiencing violence and abuse, and EAP. They've absolutely they've actually created a position that is the domestic and family violence consultation person sitting with the EAP.
good.
So the you know, it's innovative steps like those, and the creation of you know, positions that is outside the actual workplace, where you can go and speak to a professional that's employed by health. You know, that, you know, there is absolutely there is someone there that specialises in domestic and family violence.
Confidence in
In EAP, and I think that was very innovative creation of a role.
And really important, because if someone wants to access EAP and they get there and it's not a family violence trauma-informed service, they're never going to go back again. So I think, and they're going to tell their colleagues.
I mean, that is an example.
And
that position's been there nearly a year now. So
great.
Yeah, new position, it was created.
Now, there's been a couple of questions from people about the time where you get the woman alone, and we did talk about that a little bit earlier. That at the Women's, you know, you set that up from the beginning. That the first 10 minutes is just for the woman, and then the partner can come in later. So we've got a question here about that protected 10 minutes and whether that is only at the booking appointment or whether there are other opportunities to have that alone time later on.
Yeah, it is only at the booking appointment. Yeah, so it's then. But I guess that perhaps, like if something's flagged, we could probably do something at subsequent appointments, but mostly it's just for the booking appointment.
And it's interesting, women, you know, almost half of them said they'd like to be asked at every appointment. So, I mean, it is another resourcing,
yes,
you know,
right.
we would like to have time, but
Yeah.
the other appointments are much smaller, so...
Yeah.
Well, that's right, because the booking appointment's 40 minutes and then the next one's a...
Yeah, well, of course, and the violence going to escalate in pregnancy.
Absolutely.
Certainly
Yeah.
people who disclose that.
Yeah.
That's right.
Absolutely.
And I guess what I didn't mention when I was speaking before, that if, and on occasion, some people have said no, you know, I'm not, no, I am coming into this appointment. So that's a trigger and it's a flag within itself, you know. So then, you know, the midwives then sort of make a note in the notes and then we try again later in the pregnancy, and you know, and we've all done it as midwives, like make up things like, oh, we've got to come and take some blood or do a special test or something.
Yeah, they do.
Yes, because
very-
someone else has
Yeah,
pointed out here that they don't always get an opportunity to see
Yes.
that woman again as well.
Well, that's another thing. So I guess there's another plug that's what we absolutely need is continuity of care.
Yeah,
And
throughout
also
their pregnancy.
electronic medical records
Yes.
that can actually, you can document it and a flag that's not accessible to the perpetrator.
Safe and
Yes. Yeah. So would you definitely recommend that doing that 10 minutes right at the beginning of the booking appointment is the way to go, as opposed to trying, because people are asking about, you know, how do I get rid of the partner, etc. But
I think
it seems
for
like
us-
you just
Yeah, we had a lot of discussion when
Yeah.
we were developing which way we would go, and a lot of people were saying, oh, you really should get them in and, you know, establish a rapport and then move the partner out. But I just feel it's much better doing it the other way around. Just set it up the first 10 minutes.
Yeah.
But I think the experiences from New South Wales, from our practitioners, is that people do it in a whole, and Victoria, people do it in a whole variety of ways, and they are quite inventive about saying, I've got to go to the toilet, you know, I mean, not, I've got to go to the, we need to do a urine sample or we need to do an internal examination or something, and getting, but of course that's only when there's some sort of flag. It can't be in every patient, so that's the tricky part.
Yeah.
That's right. That's right.
It's not really screening then, you know.
Yeah,
it's
But as you
case
said, you'd put notices.
Yeah, you
You'd
do.
put it out there and you didn't make it personal to that midwife or that woman.
No.
I think it's a very astute way to go because you're making it a general thing. So it's not about you personally. You know, it's everyone knows.
This is how.
And yes, and you've said this is this hospital's policy or this health district's policy.
Yeah.
So I think and then all the other ways, of course. But I think that was I particularly like that. Yeah.
There's a good,
Unfortunately, you go ahead.
I was just going to say, there's a good
Wrap up
video on the Queensland Health site that talks about that particular issue.
Yeah, excellent.
We've also had a question about the screening tools used in Sustain, but I think we're going to have to leave that one. And they're all in the report anyway, aren't they, Kelsey?
They're going to be in the report, and there's a really good Australian Institute of Health and Welfare report from a few years ago that looks at all the screening tools, but I think we're all learning from each other around it. Yes.
Okay, well, we'll have to leave it there, but thank you very much to all our panel members
you.
today. So the recording of this webinar will be available on the ANROWS website on demand, so tell your friends, tell your colleagues, tell everyone to look at it. The Sustain Study report and the Real Transformation Model will be published in 2 weeks, and that will also be available on the ANROWS website. So everyone that's registered for the webinar will be emailed the documents as well. So I just want to also mention quickly that the ANROWS National Conference Evidence in Action is coming up very soon in April, and that is also going to feature a lot of discussion around reducing violence against women and their children, including responses in health settings. So you'll definitely hear more about some of this work at that event as well. So hopefully everyone's registered and going. And if you want any more information about upcoming events, please do visit the ANROWS website for more details about any of that.